Hi, my name is Rachel Brzezinski, and I'm a freshman nursing student at the University of Michigan. Today I'm going to be presenting a patient to you and explaining the reasoning behind each assessment. Due to privacy reasons, the patient's name will not be provided. My patient is a 48-year-old Caucasian woman. She is married and her current occupation is as a community life aide in a nursing home. She visits her primary care physician as well as several specialists about 4 times a year. On April 1, 2017, the patient presented with the chief complaint of joint pain and a cough. After taking my patient's vital signs, I found everything to be normal. Her blood pressure was 124/78, the respiratory rate was 14 breaths per minute, pulse was 73 beats per minute, and her oral temperature was 98.8 degrees Fahrenheit. History of present illness. Patient was diagnosed with rheumatoid arthritis in November of 2015 after having multiple episodes of joint pain. Joint pain is most commonly occurs in the patient's hands and wrists, but on several occasions she has experienced joint pain in her feet and shoulders. During episodes, patient describes her joints as extremely swollen, warm, and red. The pain is described as coming and going, and at the most intense times, patient rates her pain an 8 on a scale of 1 to 10. Patient describes her pain as burning, sharp, and shooting. Without treatment, these episodes can last for weeks at a time. Patient has been unable to pinpoint aggravating factors, but has noticed several foods cause flare-ups. As for alleviating factors, patient states that nothing has been able to relieve her pain besides medication, and sometimes even those don't work. Patient admits that this has been interfering with her daily life, as when she's having a flare-up, she is unable to zip or button her clothes, make dinner, drive, or perform many work-related activities. Patient states that her pain keeps her from doing many things that she would like to do. Patient also reports a persistent dry cough over the past few weeks. She denies any sputum or phlegm and states that no over-the-counter medications have provided any relief. Health history. All immunizations are up to date. Patient says she had normal childhood illnesses such as the chicken pox. In 1983, at age 15, patient was in a car accident in which she wasn't wearing a seatbelt. She fractured both her T11 and T12 vertebrae. Patient was hospitalized and given a TENS unit. Patient elected not to have surgery and wore a back brace for 6 months. She then followed up with a chiropractor. Patient was also hospitalized briefly for an appendectomy, gallbladder removal, and C-section of her first child. Patient is allergic to sulfa medications. Exposure results in hives, burning, and itching. Patient is currently on several medications for her rheumatoid arthritis. Methotrexate, 20 milligrams once a week, Enbrel, 50 milligrams once a week, folic acid, 1 milligram once a day, and she also has a prescription for prednisone, 50 milligrams, which she tries not to take. Functional assessment. Patient reports 1 to 2 glasses of wine once a week. Patient doesn't exercise regularly. She admits to smoking 1 pack a day for the past 27 years. However, in August of 2015, patient transitioned to an electronic cigarette and has drastically decreased her nicotine intake. She says she gets about 5 to 6 hours of sleep per night and eats a fairly healthy diet. Both children are away at college, so patient describes her support system as less than satisfactory right now. She reports that her and her husband fight often and he is her number one stressor. Patient states that she loves her job, but that it does occasionally cause her stress. Patient is Seventh-day Adventist but doesn't actively practice religion. Family history. Patient's father was diagnosed with rheumatoid arthritis at age 26. Due to the severity of his arthritis, he was on disability for most of his life. He died of pulmonary emphysema at age 62. Patient's mother is currently alive. She was diagnosed with arterial stenosis at age 70. Both the patient's brother have advanced rheumatoid arthritis and are on medications for mental health. Her maternal grandmother died of lung cancer at 77, and her maternal grandfather died of a heart attack at 79. No information was provided for her paternal grandparents. Due to the patient's chief complaint of joint pain, her history of a broken back, and her own as well as family history with rheumatoid arthritis, I will be doing a musculoskeletal assessment. Review of systems. Patient reports joint pain, swelling, redness, and warmth, most commonly in her fingers and wrists. Patient denies any deformities and states that her range of motion is limited during her RA flare-ups. She reports no noticeable muscle weakness. Assessment. First, I assessed the patient's muscle mass and bone structure. Muscles were symmetrical in size and shape, and the extremities were of equal length. The patient's spine was slightly concave due to her previously fractured back, so erect posture was not possible. Gait was even. I assessed for scoliosis and noticed that the spine was midline and the scapula, iliac crest, and gluteal folds were all even. I then assessed and palpated all the joints for range of motion, redness, inflammation, warmth, pain, and crepitus. Redness, warmth, and pain were present in the wrists and hands. Patient was unable to flex or hyperextend either wrist, and opposition of the fingers was possible but painful. All other joints were normal. In testing the patient's muscle strength, I found all muscle strengths, aside from the fingers and wrists, to be a 5 out of 5, meaning full range of motion with full resistance. In the wrists and fingers, muscle strength was a 4 out of 5, meaning full range of motion with partial resistance. Due to the patient's chief complaint of a cough, her long history of smoking, and the family history of lung disease, I also performed a respiratory assessment. Review of systems. Patient denies any shortness of breath or pain while breathing. She does, however, have a dry cough that has persisted over the past few weeks. Patient is not coughing up any sputum or phlegm. She reports no history of pneumonia, bronchitis, asthma, or frequent upper respiratory infections. Assessment. First, I inspected the thorax and found normal skin color, a 2-to-1 ratio of the anterior-posterior transverse diameter, and no obvious injuries or deformities. Her breathing was even and regular with no signs of distress. Her breathing rate was 14 breaths per minute. I palpated her trachea and found it to be midline with no tenderness or deviation. Her posterior expansion was symmetrical and smooth with no decreases or delays. After palpating for tactile fremitus, I found no increases in fremitus, and the sound diminished as I moved down the back. No tenderness, deformities, crepitus, or paradoxical movements were palpated in the ribs or thorax. I then auscultated anteriorly, posteriorly, and laterally, and observed no adventitious sounds. Bronchophony, egophony, and whispered pectoriloquy revealed no signs of consolidation. Pertinent systems. According to Dr. Osiri and Satya Sonboom in their article Prevalence and Outpatient Medical Costs of Comorbid Conditions in Patients with Rheumatoid Arthritis, hypertension is the #1 comorbid condition associated with rheumatoid arthritis. Of the 684 patients with rheumatoid arthritis who were tested in the sample, 51.2% of them also had hypertension. Because of this, I would also perform a cardiovascular assessment. Another pertinent system would be the integumentary system. As Dr. Ortiz and Grando mentioned in their article, Smoking and the Skin, there are many dermatological hazards of tobacco use that can affect the skin both directly on the epidermis and indirectly via the bloodstream. They then go on to describe the cutaneous and mucosal characteristics of smokers. Thus, it would be beneficial for my patient to have an integumentary assessment performed. That is all. Thank you.